Thanks very much for inviting me here. It's great to be in Florida. I was quite happy this morning to see that the weather in Minneapolis was going to be 60 degrees colder than here, and they're going to be minus 25 wind chill, so enjoy the time when we're here. So seamless patient experience is an interesting concept, and there's a lot of ways of getting toward it, but we really haven't seen a landing on it yet. And so I'm here tonight to spend just a few minutes talking with you about some interesting technologies, disruptive technologies, I think, that I've seen in the marketplace over the past 12 to 18 months. And hopefully, to the goals of our hosts here, begin the conversation that we're after. So our elected officials are toiling away with great progress and ensuring that our patients have healthcare coverage, that unexpected hospital charges don't happen, and that pharma is affordable. And we have to start off with the evil joke about the doctors only interested in insurance. And I feel sort of bad because I think as I look at my primary care colleagues, this is often too true. And the reality is that most of us don't have the time anymore to focus on something as trivial as health insurance as we're looking at outcomes, liability, and efficiency in our practices. So when we think about the concept of seamless healthcare, what does that involve? And I guess the first way to start thinking about it, at least as I've approached it, is thinking about the problems a little bit. So healthcare is by nature asynchronous. And I think for many patients, based upon their work and their health insurance and the scarcity of certain specialty providers, it's even more asynchronous. Synchronicity is not necessarily a solution, but I think it's clearly part of the problem. And we hear that patients are frustrated because they have to go to many destinations to get their care. Scheduling your health care is really cumbersome, and despite the fact that our EMR companies think that they have digital offerings to schedule health care, they all are just terrible. I mean, the one that we use up in Cleveland functions, but that's probably the nicest thing that I can say, and quite frankly, I don't think any of the major EMR providers are any better. So finding time to get care actually compounds the problem. And then actually getting to healthcare is frustrating and expensive and time-consuming. And when we talk about time, I think it's increasingly important that we consider the issues around work-life balance, because patients are really frustrated and employers are frustrated and are now focused on and measuring productivity and outcomes based upon absenteeism. So this is Angela. It's not her real name, but she's a real person. She's 62. She's a product manager for a health technology company near Philadelphia. She's got some mild chronic hypertension, which is well managed with an ACE inhibitor. She's got some dyslipidemia and is managed on a statin. She had her appendix out when she was a kid. She's had a kidney stone and had polycystic ovary disease and had a hysterectomy and oophorectomy. But she's been attached to a practice for about a decade and is reasonably healthy and obviously quite well and productive in her work and family and society. And she woke up over the weekend with left lower quadrant abdominal pain. Now, I might joke that she got upset over the Wisconsin-Ohio State game, but I'm married to a Buckeye, so it's just complicated, particularly with the Michigan MBA. Ooh, yeah. Yeah, well, you know where my loyalties are. I don't have to sleep outside. So anyway, she's now at work on a Monday morning. It's 8:30, and she's got belly pain that's gotten progressively worse over the previous 36 hours, and she decides that she needs to consume care. She doesn't spend time at the doctor when she doesn't need to. She's stable and productive. What does she do next? She picks up the phone and she calls the practice. And she gets to the secretary or the nurse who's now looking at the monitor in the way that we do on Monday morning when all the disasters are arriving and the schedule is overbooked. And the secretary says, yeah, we have an appointment for you on the 23rd of December, 2 Mondays from now, and we can see at 3 in the afternoon. That doesn't work. What comes next? The 8 deadly words. You need to go to the emergency room. Anybody ever had to go to the emergency room? Hands up. Wow, sorry, me too. Yep, so we go to the emergency room and you sit in the waiting area and you get triage and you can sit around with 40 of your newest ill friends and then you wait to get care. Now this is not really fair. This is actually, I think, one of the New York hospitals during the February flu outbreak, but that's not uncommon if you're at holidays or weekends or they're changing the residents or there's some endemic pandemic or mass trauma. And that's sort of the highest quality of care. And the primary care providers don't have the capability to integrate those patients into their daily schedules because they don't have the time, they might not have the expertise, Or perhaps the hospital systems that own them say, when you have these cases, we'd prefer that you send them to urgent or emergency room care because our margins are higher. And that's just a reality of healthcare delivery today. So then what happens next? Well, get seen by a physician staff member. Hopefully they don't belong to a national group with aggressive VCs that will chase you for your unpaid bills. Have some phlebotomy tests, phlebotomy charge and your laboratory tests. Get some IV fluids, an abdominal CT scan. You pay the radiologist his pro fee to interpret it, and you get some antibiotics because she's got, in fact, mild diverticulitis. It's a real case, but she didn't actually get care this way. And if you look at outcome data for hospitals in metropolitan areas around the country, the bill for this kind of an encounter would be between $4,000 and $5,000, and the patient would see a copay of probably about 20%. And this is sort of the best that we have available now. She got the care she needed in this environment, but it's a terrible experience. She lost an entire day of work. So is there a better way to move forward? So it's interesting because there's a number of technology approaches that are out there, and there are many vendors, and I'm not here to promote one or the other, but I'm going to show you a couple that really are focused around the concept of interesting ways to break up the current state of affairs and create what looks like a more seamless event. So there have been studies in the advisory groups, and there's been news published about this. What are the patients telling us about their pain points in healthcare? Access to timely care is always number one. I need to be seen when I need to be seen, whether it's acute or whether I need to schedule my wellness physical before my plan year runs out. I want to be able to get my health care in a variety of locations, and while I might have a primary care practice alignment, which is fine, I don't want necessarily to be bound to a given hospital system. Part of that's insurance, but part of it is opacity around finding where to go and when. I already mentioned work-life integration. I would say that this shows up pretty close to number 3 in most of these kinds of surveys. We've already talked about employers looking at this from the standpoint of productivity. But patients don't want to really spend their time going to the hospital. They want to be able to be at home, productive, working, and integrate healthcare into life, not organize their life around healthcare. There's ambiguity about follow-up. What happens next? She got treated with antibiotics. What do I tell my primary care doctor? Who do I see next? There's an after-care summary, a sheaf of papers. Maybe there's an EMR transmission. Who reads that? Who knows how to bring it together? Patients are getting bombarded by insurers and employers and practices who are in shared savings and value-sharing arrangements about prevention and wellness. And how's the way that we integrate this into care without having yet another call, another app, another letter in the mail? And then finally, they're really frustrated, and this has been in the news every single day for the last 3 months around cost opacity and how their insurance plan will cover their needs. I think one of the fundamentals is that keeping the patient in front of their primary care provider is really important. Remember, in this case, this woman, in fact, was aligned with a practice she's been going to for a decade. They know her. She trusts them. And so I think tools that enable that are actually quite interesting. So if we look at a seamless patient experience and we wanted to throw technology in front of it, and these are just graphic images that I put together, we use Google Maps to find everything. Restaurants near us, where the closest Uber ride is, et cetera. That's an access to care tool. Cost and insurance transparency. We use scheduling apps to book restaurants and just about everything else. Ease of scheduling. So not only how much is it going to cost, but when is it going to fit into my calendar and integrate into my smart device or watch or what have you. And then technologies that really center the patient in the continuity of care circle, which really brings to the point around follow-up, ambiguity, wellness reminders, and ongoing connectivity with their care providers and insurer. In our practices, I think that we feel the same pressures, and I still have an appointment at the Cleveland Clinic. I don't have a primary care practice, so I can't speak to it. But we want our patients to be sticky, we want to have connectivity, and we want to know what's going on with them so that we can be more effective with our time when we're in front of them. And by the way, for those of us physicians who are patients, we also feel these same pressures in the role of patients, that timing in our practices is very challenging. challenging. Access to care is maybe a bit easier, but how often do we have to call on favors from colleagues in order to get the appointment that we want? So by show of hands, how many in the room can get to see their dermatologist this Wednesday if they made a call tomorrow morning? Good for you. Are you a dermatologist? No. Good. There was an interesting article in, I think it was Doximity a couple of weeks ago, about a woman physician who had a husband who needed specialty care and he couldn't get an appointment. And so she went through her network of physicians trying to apply favors to get him in to be seen, and she failed. Now, part of it has to do probably with scarcity of that specialty care. You could wonder about what her reputation in her medical community might be. But if you practice at the Cleveland Clinic, our CEO said, physician patients are no different than patient patients, and we mustn't, for ethics, treat them differently from a scheduling and access to care perspective. And I think we're going to see more of that, and I really don't say that I can argue with it. So the first platform I'm going to tell you about is very interesting. It basically creates the concept of concierge-level access for all patients in a primary care practice without actually creating the concierge model as we know it now. It's a fully digital solution. It connects patients to their physicians and their advanced practice partners. It allows the practices to extend coverage of their hours. It fully integrates into the EMR, so these messaging events turn into notes that can run into the EMR and be coded, and it helps the practice efficiency in a variety of ways. The nice thing is the patient feels like they're getting a concierge service agreement without having to pay the $500 a month and deal with some of the pressures about how we see concierge practices actually working in the community today. So let's go back to Angela with the abdominal pain, and she was actually cared for by a recent rollout of this technology platform by a university and community health system on the East Coast. Again, this is real-time interaction with her practice, but she's not physically there, and it's not through a traditional video telehealth interaction. It uses asynchronous messaging. And the practice, just like when you call or chat with Amazon, Costco, American Airlines, is dealing with multiple customers at the same time with the single agent. It's a cell phone app. So Angela logs on and she's connected to the nurse practitioner that works in this practice. And the nurse practitioner knows her. And Cindy has had clinical interactions with her during the time of the past years that she's been there. Cindy hears from Angela what her symptoms are, why it's different, how long it's been lasting, some very simple initial interactions in the same way that you'd be getting a review of systems, chief complaint from the patient. It's been going on for about a day and a half. Yet timing for the Wisconsin-Ohio State game is just too unnerving. Fever and chills, bowel movement, the kinds of questions that you'd normally ask. Remember, this is happening through a chat application. It's fully secure. It exists on the patient's cell phone. And this can be done using a computer, a cell phone, or a tablet in the practice. So Cindy, the nurse, looks at the schedule and sees that there's actually a slot that's open now at 4:30, but that's not going to really help. But she says, why don't we get some labs and check you at the Connexion that's located at your office? And we'll talk about the Connexion technology next. That works for Cindy. Great, I can run over to the lab on my break and go to Connexion over lunch. Connexion's in her workplace, so she doesn't really have to go anywhere. Fine, I put your labs in. There's a lab over on Orange Street. She drops a pin on a map. It pushes to her app. Cindy goes and gets her labs from LabCorp or Quest or whoever runs the labs. Sounds great. Feels great. So let's talk about millennials. I have 2 kids. My son is going to be 23. He argues with me that he's either a millennial or a Gen X, depending upon what point he's trying to make. They're very, very, very different. At our table at dinner, I heard some of my colleagues talking about training millennials. I'm glad that I'm not in that position anymore. I might be sarcastic, but they have a very different view about their health care. They really take it into their own hands, the concept of the paternalistic doctor-patient relationship. They don't want to have any part of it. They do their research. You know, when I started practice, it was pre-internet. I had to put up another cartoon. These are not the millennials. They've done their research. They are completely opposed to surprise billing. They want complete cost transparency to everything. They have it for their meals, for their travel, for their dating, everything, and they won't tolerate it. Everything has to be on apps. They do everything. They eat, they travel, they date, they bank, they work on their apps. So they want to be able to have that. They're certainly not going to have telephonic case management. Healthy is not just not sick. It's a life experience and a continuum. It's very important, and they want to be invested in that. And they're also incredibly precise when they're shopping insurance, and they make decisions about levels of care and how much they're willing to pay based upon how they perceive their risk of getting sick during a plan year. And it comes down again to some of the things we talked about before: reliability, price transparency, and convenience. So Angela went to the Connexion in her workplace, and the Connexion is an interesting device. This is another company that I've had a chance to look at. I think about this as sort of a large format apps platform for healthcare, and where there's a Google Play environment that vendors can write apps to run on it. And these devices can be configured to do screening in telehealth. They can be in workplace for wellness and HRA participation. There's universities and professional sports teams using these for physical training and rehab, because there are apps using the very high precision sensors and cameras that are far more accurate than professional physical therapists. And these things can be put into a variety of formats and locations in work facilities where I've seen them deployed. Some medical institutions are now starting to roll them out in retail locations. There's a university on the East Coast who's going to put one adjacent to their health center in partnership with a pharmacy. So the kids can get access to health care and then go to the pharmacy and buy what they need, which I've learned from my college kids are cold and flu medications and things for hangovers. So Angela walks up, she authenticates using her biometrics to her phone, she scans the QR code, and there's a secure linkage between her and this device. There's not the ability to perpetuate healthcare fraud any more than we can perpetuate fraud using our device from fingerprint or facial recognition. And then in this case, she sat down, she got her biometrics and sat down in the device and got traditional vital signs screening. In the workplace, quite easy, quite private. These are some examples from their commercial deck. You know, these devices can be located anywhere in the country. They're connected to a power supply and to the cloud. And so if Angela were actually traveling on the West Coast, she could find a Connexion near me and go there. This is a mock-up of the retail format that one of the pharmacies is going to use. And of course, they integrate into smartwatches and apps as well. So when you walk in, if you have activity data for a health risk assessment, it'll transfer off of your devices into the Connexion automatically, depending upon the app. So she's been to the lab, she's gone to the Connexion, she picks up the chat app again, which she can either do on the big screen of the Connexion or back on her cell phone again. Hi, I got my labs and vital signs. Yep, okay, your heart rate's up, you've got a fever, and you've got leukocytosis of 12.8. What's next? So remember, this is an asynchronous chat. Cindy's not sitting in a video screen in front of her, so if there's a minute or 5 delay, Angela's not upset because this is an idiom she's used to. The APN talks with the physician who thinks this looks very much like diverticulitis. She had diverticulosis on a colonoscopy, and they recommend that we should get a CT scan. Now, if you look about the continuity of care, this is exactly the same thing that would happen in the emergency setting, but in an asynchronous, tech-enabled way. So I want you to go get a CT scan, no problem. I told my boss I'm not feeling well. I can take the afternoon off. Cindy schedules a CT scan, drops a MAT pin into the application, and Angela walks down the street to an independent imaging center to get a CT scan. When we looked at this case, it was just over an hour from the initial contact. Hadn't been to the emergency room, hadn't been to urgent care, walked down to the street to get some labs, and went to the company health center to get their screenings on their time. CT scan's now done. How are you feeling? About the same. No surprise. You got some diverticulitis and some associated inflammation. Sent an e-prescription to the Rite Aid down the street. Dropped another MAT pin. All sorted. Here's the follow-up. I've set a note to contact you in 48 hours. It gets towards the concept of continuity of care. And I've put a note that we're going to refer you to a gastroenterologist sometime later, 4 to 6 weeks from now, to evaluate whether there's dietary changes or anything else that we need to look at. Great. What do I need to worry about? This is the same sort of things we'd say in our practice or in the emergency department. If you feel worse, recontact us. If you really get sick, go to the emergency department. But they haven't been to the emergency department yet. Total time was 2 hours. Now, in practicality, the good news in this specific case, there was a CT scan slot available within a very short time frame. But it's still going to be less than half the time that they'd spent if they'd gone to the hospital in the same municipality. 6 to 8 hours, $4,000 to $5,000, $800 to $1,000 copay. 1 to 2 hours using this tech platform, $50 copay for the labs, $160 for the CT. Telemedicine visit was free because the employer incents the employees to use that, and there's no copay for it, and a $10 copay for Cipro and Flagyl. About 2 hours. Patient's very happy. So there's another startup that came out of New York, and I really like these guys because I think they're very impressive and they're really rascals and disrupting. This is really, I think, squarely targeted at the millennials, and they are now tracking about 50 to 60,000 physicians and have between 8 and 10 million live quality reviews. And they found a way to disambiguate the reviews so that you couldn't put fake reviews in. These are actual patients talking about their physician experiences in their practices. And now they've developed tools where applications can rank specialists in the order of their quality and then show that quality ranking in the context of their calendaring. It's nirvana for the millennials because they can control the things that drive them crazy. Now, this is really interesting and I think very controversial. They've taken the same concept and morphed it into the idea around dynamic pricing. We get to thank all the guys at MIT for doing this, but dynamic pricing surrounds us everywhere. In this example, not real physicians, you can see a 5-star physician today for $200, a 3-star physician today for $80, a 3.7-star physician in a week for $110. You can see Dr. Schmatz, who has the lowest copay and 2 stars, and he's not going to do very well. It's interesting because the millennials like this in these initial pilots because it allows them to prioritize price, convenience, and quality in a way that they've never been able to see. What's interesting is talking to physicians who are faced with this potential because now the physicians are looking at time in their practice as an asset or resource that can be treated in an opportunity cost model. And if there's a high volume recognized specialist, he or she can then use this kind of dynamic pricing to leverage more cost efficiency and revenue out of their time than they might get from standard insurance contracting. Lots of people don't like it, but lots of people didn't like a lot of things now that are completely common, like paying to check your baggage. We'll see what happens over the next couple of years. So we talked a little bit about the context of how the technology levers engagement around asynchronous chat, care team collaboration, reminders, and follow-up and handoffs. In the case of the diverticulitis, the gastroenterologist that the practice refers to is on the same platform, so he got the entire encounter as well as the epic note shared, and there's time efficiency in not having to relearn that information or trying to get the patient who's not medically sophisticated to remember it a month or longer later. Again, the platform would be idealized if you could integrate personal goal setting and tracking. We're all wearing some kind of device that nags us about walking and eating and caffeine and sleeping. And so if this came together, it's one more focus of unification. The employers, the insurers, and the care teams really like it because they can use this platform potentially to pour their apps into it as well. The insurers and employers can drive toward cost efficiencies. The care teams can work towards stars or shared savings goals if that's part of their practice arrangement and participation with local payers and hospital systems. And then, of course, the review schema, I think, is going to transform the way we look at how we consume healthcare because physicians historically have been enablers of our less capable colleagues. So we talked about seamless. How does this align the patient and the practice together? Well, I think the most important thing, and I think the thing that encourages me most, is that Patients can look at this and say, I get to stick with my doctor, but I get to my doctor at the time that I need them more easily. I feel like concierge, but I'm not paying a lot. The insurers like it because they have the ability to lever behaviors and care path choices, in this case towards consumption of telemedicine resources. Easier way to find specialists, a little less ambiguity about whom, and certainly, as you've seen, the ability to know when you can see them, and you can make choices based upon time, cost, and quality. Wellness reminders are integrated, and again, it ties things together. We all use messaging for everything. It's now inextricable. Even my 83-year-old mother does, and so I don't think that this is a disruptor anymore. I think we just need to find a way to make it work better. And then employers love it because they have employees and HR assets that are engaged and available and will help them drive their costs down and will be happier and hopefully more efficient. So the final piece is, what does the practice get out of this? The office and staff reminders, actually I was surprised to hear as we talked to some of the initial adopters of this, were quite high on the list. The unification of something that didn't involve notebook spreadsheets or Post-it notes was actually sought after, and you'd be surprised how much of that is still in the business. One APN can safely manage many patients, just the same way that asynchronous chat happens when you get customer service today. This then leans into staff scheduling efficiencies because this functionality can move over into the on-call coverage because you don't have to be in a brick-and-mortar location. The practice uses this on a tablet or a computer as well. And so if you have on-call physicians, they can extend office hours without having to increase their staffing. It's great for ACO and STARS goals because you have a unified platform and the patients want to come back to it. Of course, EMR integration is absolutely necessary. And this wouldn't work unless it generated notes that pushed into the EMR that were secure in real time and didn't have to involve a year of Epic Web Services program. It just uses standard messaging. And finally, there's telemedicine revenue. Remember, the practice got $59 of telemedicine revenue as approved by the CMS codes and the local insurer in the marketplace. Thank you so much for the opportunity to share some insights about technology. And I'd be happy to talk to you after dinner's over. Thanks very much.